Good morning, everybody. I think we can go ahead, Natasha. It's 9:32 and it's being recorded, so if they miss the first couple, they can go back and watch it.
Okay. So we're covering respiratory disorders today. Here are a couple of links that Ms. Conley has on here for you guys to review. We'll start with just some basic anatomy. Sorry about that. Can you guys hear me? Okay.
Yes.
So sorry about that, you guys. So respiratory anatomy, we just start with the upper airway. It consists of the nose, the sinuses, the turbinates, the pharynx, and the larynx. And then we have the paranasal sinuses, the frontal, the ethmoidal, the sphenoidal, and the maxillary. And then we drop down into the lower airway, which is the trachea, the bronchi, the bronchioles, and the lungs. So the internal nose is divided into two categories, which are separated by the nasal septum, and the whole purpose of the nasal passage is to warm and humidify inspired air via the vascular areas and the ciliated mucus lining. So that's just a brief cover of anatomy again. Accessory structures include the diaphragm, which separates the thoracic and the abdominal cavities. Then the mediastinum, which is the wall that divides the thoracic cavity into two halves. And then the pleura, which is the sac-like serous membrane. You have the visceral pleura that covers the lining of the lungs. The parietal pleura, which covers the chest wall. And in between each of those is serous fluid, which lubricates and it allows the lungs to expand and such. So respiratory physiology, we have the main functions of the respiratory system are to do O2 and CO2 gas exchange between atmospheric pressure and the blood and between the blood and the cells. The first word we have is ventilation, and ventilation is basically the movement of air in and out of the respiratory tract. This video right here on gas exchange is a good video if you guys want to watch it. Let's see. I broke it down just a little to cover it real quick with you guys. You have ventilation, which is the movement of gas in and out of the lungs. Diffusion, which is the gas between the lungs and the blood. And perfusion, which is the blood flow into the tissues and the organs. So that's just a quick breakdown of that video, which is a really good video to watch to understand it. If you understand the anatomy, the pathophysiology of a system, it helps you understand when something goes wrong, how to treat it. So I would strongly recommend you guys make sure you understand those. Some of the font has messed up a little in the conversion, but again, this is the same PowerPoint you guys have. We have problems in the respiratory physiology. Respiratory insufficiency develops if there is too much interference with your ventilation, your diffusion, or your perfusion. So getting air into the body, getting the lungs to do their job of getting oxygen to the blood, and then when you're in your body, actually the blood getting the oxygen to your tissues and your organs. Okay. We have some abnormalities such as hypoxia, which is decreased oxygen in the inspired air, the air that you're breathing into your body. And then we have hypoxemia, which hypoxia and hypoxemia are interchangeable in some settings, so don't be surprised if you hear them used as for one another, but that's decreased oxygen in the blood. Hypercapnia, which is increased CO2 in the blood, and that's carbon dioxide, and hypocapnia is decreased CO2 in the blood. Okay. Hypoxia, let's see, affects tissues, organs, body's your overall body. And then again, hypoxemia is low levels in the blood. Hypercapnia, that you can see that when someone's hypoventilating, they're not breathing properly, they're not getting that exchange, and they're collecting that CO2 in their body. And the hypercapnia is the complete opposite. They're hyperventilating, and they're doing too much inhalation, they're getting too much oxygen, and they're not balancing that CO2. Okay, and so these imbalances, they lead to respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So that comes, we're starting to come into the ABGs, which is a big deal. It's not so much understanding, or not understanding, I'm using the wrong word. What you want to do is figure out how to apply these numbers to a nursing situation. I don't think the boards really ever asks you to figure out one of the equations and say, is this happening or is this happening? It's more along the lines of, if this is going on, what should you do? So here we have the pH scale. Acid is all the way down here on this side. To the left, it goes down to 0. For example, batteries are at a 0 on the side of acid, and your gastric acid is a 1 on this scale. Water, pure water, is the number 7, so it's right in the middle. And then alkaline, which is your base, is like oven cleaner all the way at 14, or bleach at 13. So that kind of gives you an idea of where we are on the scale, and the things that we take into our body, and the balances of the organs in our body. So this video is a really, really good video. I'll be honest, I haven't done ABGs in a long time, and she breaks this down in a very good manner. It's the tic-tac-toe. What the big takeaway from this video is to understand your values. Let me see if I can pull up this whiteboard. I was going to type it out for you guys. No, give me just one second, guys. Okay, so the way she does it is she has on here, she gives you your ranges. You have pH, which is 7.35 to 7.45, okay? This side over here is your alkaline side, so that means it's basic, and then this side over here is your acidic side, okay? Okay, sorry guys. So let me pull up, how do I share this? Okay, sorry guys. I guess I'm just gonna, oh, you see it now? Okay, perfect. All right. And then over here, she's doing your PA CO2, and that's alkaline on this side of the scale at 35, and acidic on this side of the scale at 45, okay? And then we have, okay, all right, that's fine. And then HCO3, which it'll pop up for you guys in just a second, is acidic on this side at 22 or 22, and then 26 is going to be alkaline. Okay, so can you see the pointer moving around? This right here, your PaCO2, that's indicative of the respiratory system. Okay, so let me type that out for you. PaCO2 is respiratory. Okay, and then your HCO3 is metabolic. Okay, Okay, that's fine. Just know the first one, your pH, that's your basic scale. Your PaCO2 equals respiratory, and your HCO3 equals metabolic. So this is where your Rome comes in. I'm not sure if you guys have looked at the handout Miss Conley has for you guys, but it goes into more detail about this along with that Visio. But the video, sorry, respiratory is opposite, and metabolic is equal. Okay, that's where Rome comes in. So respiratory right here is opposite from, darn it, this pointer. Let me do this one. Can you see that now? Perfect. So respiratory, your PaCO2, your alkaline right here is opposite than acidic. So, and what I'm saying when I mean that is the first number on the pH is acidic, and the second number on the pH is alkaline. So the first number on the PaCO2 is alkaline, that's your 35, and the second number is acidic. So if you look at it like that, these are opposite one another, okay? So respiratory is opposite, metabolic is equal. So your HCO3 is metabolic, that's your basic scale. So we have acidic here, alkaline here, alkaline here. Okay, so metabolic is equal. So if you just remember those simple things, you want to remember the actual numbers, your reference range. You want to remember which side is acidic and which side is alkaline. That helps you significantly. And then she goes further on in this video to do the tic-tac-toe method, which is simply where, this is, I'm not an artist, people. She's going to have 3 boxes or 3 lines, and she'll have acid. I'm doing this with the mouse, people. Neutral, and then base or alkaline. Okay. And then when you get your problem, when you get your numbers in any one of these equations, it's going to give you your PaCO2, it's going to give you your pH, and it's going to give you your HCO3. So what you're going to do is this is your this is your basic side, and this is your acid side, okay? So let's just say you got a 7.53 for your pH, right? So 7.53 is going to be alkaline. So you can do pH right here. Does that make sense to you guys? Am I going too fast? So 7.53 on your pH is going to be alkaline. Okay. And then the next number is 23. That's your PaCO2. Correct. And your PaCO2 is going to be 23. Well, 23 is down here. That's alkaline. So you're going to do PA over here. And I'm just going to do an abbreviated version because, again, I'm using my mouse. Okay. And then you have 18 for your HCO3. And 18 is acidic over here. Okay, so it's on this side. So HCO3, we'll do HC on here, is over here. So you have more of the tic-tac-toes. You have a full tic-tac-toe over here on alkalosis side, on the base side, okay? So, okay, yeah. So we have respiratory alkalosis partially compensated. And I know this is probably not the best example. It's, I mean, for you to see, to understand because of the writing thing, but it's basic like that. It's very easy. It's so much easier. Do one that is not compensated. Okay.
I have a question.
Yes.
Okay, so maybe I'm just misunderstanding it. I watched the video and everything, but if PaCO2 is respiratory and then HCO3 is metabolic, correct?
Yes.
So when it's like tic-tac-toe 3 in a row and it's got HC and pH, is it not metabolic?
HC and pH. Yeah, you're right. I'm looking at the wrong numbers. I just reported this incorrectly last night.
Okay.
Yeah, you're right. Yeah, no, I'm sorry, you guys. This is you're right. You guys are right. This is the first example she shows on that video. I mixed up my numbers. So you are correct. In this situation, it would be metabolic acidosis. Yes.
Okay. I was just making sure. Thank you.
No, thank you for correcting. So, in this situation, let's say we have, so this is our pH, this is our HC. So let's say, okay, so let's say our PaCO2 is 36. So PaCO2 right here means it's uncompensated. There's nothing the body's trying to do to fix this. Okay, and you guys, that video explains it so much better than I'm doing right now with this chicken scratch, but it's very user friendly and easy to understand. Okay, to go into it a little further, I'm going to just show you guys this. Let's see, share now. Okay, so this little chart down here that Ms. Conley provided you in the Turn ABGs into Child's Play, this gives you an idea of what I was talking about earlier, where you want to make sure you understand more so the effects it has on the body than necessarily how to get the answer, if that makes sense to you. Okay, so for metabolic acidosis, it results from things like diarrhea or renal failure, sepsis, stuff like that. And you can remember that simply by metabolic acidosis, ASS. You've got stuff coming out your butt, and that'll help you remember that metabolic acidosis is just, from diarrhea and stuff like that. Too much stuff coming out of the body. Okay. Metabolic alkalosis would be like vomiting or hypovolemia, stuff like that. And then you have your respiratory acidosis. It's where you hold on to CO2 too much, and it shows you on there's COPD. So that's just body, because the lungs are damaged, the body's holding on to too much CO2, and you don't have that gas exchange like you want. Let's see, and then finally, respiratory alkalosis is, if you have anxiety or you have an anxiety attack, stuff like that, you're blowing too much out, and that can cause the respiratory alkalosis. Okay.
I just want to chime in and help with this one. So y'all guys can hear me?
Yes.
Okay. So for NCLEX, the kind of questions you'll get are, hey, your patient's having this problem, that you can see or whatnot, and they'll want you to pick out which acid-base imbalance do you think that they have. And for like the metabolic acidosis is, like what Natasha says, is it could be from overuse of laxatives, which causes profuse diarrhea, and also in metabolic acidosis is the ketoacidosis, the diabetic ketoacidosis, and where you'll see increased ketones with that. And so with the metabolic acidosis, I like to say the metabolic acidosis comes out of the ass. Okay, that's on time. But it helps you remember. It has the AC and ASS. It matches to me. Y'all don't know I do weird stuff to remember things. But so in metabolic, meaning they're not having a respiratory thing going on. That's not their major problem. So when you have a respiratory acidosis or alkalosis, they're having some sort of respiratory problem. So you can automatically say, well, I know it's going to be a respiratory something because they're having a respiratory issue. They're not having a respiratory issue, they're having something else with the internal organs, like with GI stuff or whatnot, or infection. So going back to the opposite of metabolic acidosis is metabolic alkalosis, and the most common thing that they'll want to know is why someone would have metabolic alkalosis, the basic one, and that's usually from too much GI suction. So too much NG tube suction is where you're going to get this one. So it's losing gastric secretions. That's from vomiting too much, or the GI suction, maybe the suction is high instead of low, intermittent, and that's going to be the main one. Also with here can be potassium wasting diuretics, where you're going to lose potassium, which has hydrogen ions with it. So you are going to have the alkalosis with that one too. With the respiratory acidosis, that's always going to be your people who have lung disease. Okay, your lung disease people are going to be respiratory acidosis because they're holding on to the carbon dioxide and they can't blow it out. So that makes them acidic inside their blood. So your respiratory distress, pulmonary edema, COPD, airway obstructions like asthma. So that's going to be acidosis for lung diseases. The treatment for that is to give bicarbonate. That's an IV, something you can give. Of course, we give them bicarbonate, which is the base. It's going to raise the acidity of their blood. Okay, so the opposite, respiratory alkalosis, this is going to be that group standing at the altar who's hyperventilating because he's not so sure if he wants to get married or not. Okay, so alkalosis is the basic part, and that's mainly from hyperventilation issues, anxiety. Let's see. They're blowing off too much carbon dioxide, something that makes them hyperventilate. And y'all know what the treatment for that would be? Y'all unmute yourselves and tell me what's the treatment for hyperventilating. This is a white people thing. Unmute yourself if you're talking. I can't hear anybody.
You said treatment for hyperventilation?
Yeah.
Maybe something for anxiety?
Yes, that would be a
Like
correct
Xanax
answer.
or Valium?
Yeah,
Asthma pump.
A brown paper bag.
A brown paper bag. That's right. Have them breathe into a paper bag. So if someone is having like panic attack would fit here. Breathing too fast, too much, cause from anxiety. Hyperventilating, breathe into a paper bag, or sedate them would be the intervention for that part. So with the acid-base stuff, all you really need to know is how to do the tic-tac-toe. With the simple things, you will rarely ever get a question about compensated or decompensated. So you can avoid those ones, but you do have to know the normal values and where they go in the box. You can pick out whether they're respiratory alkalosis or metabolic alkalosis or whatever it is. So a simple conversion there, and then the main thing is knowing which conditions causes which acid-base balance. And I'm going to turn it back over to Natasha.
Okay, thank you for clarifying that. So we'll move on to breath sounds. I know you guys are missing out on clinical, and Ms. Conley and I actually were talking about that. So we have some stuff that we might be able to set up for you guys, but you still need to understand your breath sounds, and you do that by auscultating. And a normal breath sounds they're vesicular breath sounds, which are produced by air movement in bronchioles and the alveoli. Bronchial sounds, which are produced by air movement through the trachea, and bronchiovesicular sounds, which are normal breath sounds heard between the trachea and the upper lung. And this video right here Ms. Conley has on here for you guys. You can go and practice listening to breath sounds. In the escape room that we did, there's also an area where you can practice listening to breath sounds as well. So this is the how you would auscultate the lungs. Some people do the whole right side and then the left side, but the proper way to do it is the bell on the skin, so stethoscope on the skin, and you start on one side and you go to the other and you follow it around because you want to compare what's on one side needs to be on the other. And if you don't, there's your abnormality. You can listen and you can hear where someone has pneumonia. You can hear where they might have a collapsed lung. You can hear where they have diminished lung sounds because the lungs aren't working properly in certain areas due to COPD. So this right here, this is your anterior view. So you'll start at the top and work your way down. It's important to get the bases of your lungs on the front and the back, simply because that a lot of times that's where you'll hear your decreased sounds, or you won't hear sound because it's decreased. This is your lateral side. So you'll start right just a little below the armpit and work your way down. And again, this comes back around to the back. So anterior, lateral, and so now we're on the posterior. And again, there are a number of different ranges as far as like 1 through 9, what people listen to. This is the full assessment. Sometimes you'll do an abridged assessment, meaning you might not listen to all 9 spots, but for each time you have the bell on the person's skin, whether it's on the front or the back, they have to take a full breath in and out. Okay, so there's that. This is an example of where you're going to find or where you're going to hear the different types of lung sounds. So bronchial, it's going to be over the trachea, shows you right in this area. Vesicular, going to be on the outer parts of the lungs. And then bronchiovesicular is the actual branch and then branching out. Okay. This goes into breath sounds. And again, the escape room has it where it breaks down. You can go on YouTube. There's so many different places where you can practice learning breath sounds. It's very important for you to understand or to know what sounds like what. Okay, so crackles, which were formerly called rails, they resemble static or the sound made by rubbing your hair strands together. If you rub them together, it truly does sound. If you rub your hair together, it sounds just like that. And sometimes it can get cleared out when you cough. You have wheezing. We've all heard wheezing. If you've heard anyone with asthma or anything like that, you hear wheezing just when they're breathing out of their mouth. But when you put the stethoscope on their chest, it's so much more clear, and it has a hissing or a whistling sound. And then you can have a deeper sound lower. You can hear it during inspiration or expiration. Sonorous wheezing, which were formerly called bronchi, they're lower pitched and they're heard more in the trachea and the bronchi. So right in the middle of the chest and in the middle of the back is more where you're going to hear those sounds. And friction rubs are heard as crackling or grating sounds on inspiration or expiration. Some people have described it as like walking on snow. If you've ever walked on snow, how that sounds is definitely a distinct sound. You'll know it when you hear it. Ms. Conley has this video where you can practice listening to lung sounds and guessing, and she has the answers on the next slide. So go ahead and practice that. It's not something we're going to pull up today, but definitely practice it so you feel comfortable with it. Okay, so there's your answers. Let's see. And we're going to move on to the diagnostic tests and what they're for. Okay. So we have ABGs. This is typically in the hospital setting performed by your respiratory therapist. As having worked in the hospital, I've never had an RN do it, but it is very important, again, like we discussed earlier, to understand the results of acid-base imbalances, okay? So PaCO2 is partial pressure of oxygen PaCO2 is partial pressure of carbon dioxide, and HCO3 is the concentration of bicarbonate in arterial blood. This can be done at bedside, meaning if you're in the hospital, they'll come to your room. This can be done outpatient, however the doctor orders it, and wherever the respiratory therapist or the RN are available to draw them. Okay. Let's see. We have pulmonary function tests. These are typically done outpatient. Your doctor or the pulmonologist or even your primary doctor will order it. It determines the lung function and breathing difficulties. What you'll do is you'll blow in and out of this device, and it measures how well you're able to do that. And let's see. Pulmonary function tests, it's an umbrella term really for several different tests. And one, for example, measures lung volume. The other one's for spirometry. So there's a couple of things you want to instruct the patient to do prior to. For smokers, you want to tell them they're not allowed to smoke for 6 to 8 hours prior to testing. And for anybody who uses an inhaler, they need to withhold or not use their inhalers for about 4 to 6 hours prior to the testing. Does anybody understand, or anybody want to elaborate on why that is, why you don't want to have those things in your body? It is as simple as you think it is. Anybody want to?
You want to get an accurate reading?
Correct. You don't want to have anything in the body that can alter the reading of your lungs. So that's good. Perfect. Next, we have bronchoscopy, and it says it's done in the OR, and it can be done in the OR, but as the picture shows in the next slide, it's done at bedside. And this is something, even as an LPN, that you, if you're working at the hospital, you might assist at bedside. Yeah. So that's something for you to, or ambulatory care, correct. You'll have it's usually the doctor and the respiratory therapist and the nurse in the room. And the respiratory therapist is in charge of doing the sedation and stuff. The doctor obviously is going to do the equipment, and then you do whatever else is needed, whatever they need you to do. But basically, the patient they get their sedation. It could be general or it could be a local. It's simple things. You want to have them remove their dentures. They're not supposed to eat. Okay, so the nurses, yes, like Ms. Conley said, you're going to be handling the specimens and stuff like that. So they're going to be NPO, so nothing by mouth for about 4 hours. And you want to verify what meds you're allowed to give by the doctor, okay? So during the procedure, the patient's going to be sitting or supine. As Ms. Conley said, the nurse is going to be labeling specimens, getting stuff prepped to send to the lab. You're going to monitor vital signs, and you want to have an ambu bag in case of bronchospasms or laryngeospasms. And the ambu bag is that round one that has the mask connected to it that you'll squeeze in and squeeze out. Let relax to get air into the lungs. Okay. So after this procedure, you want to monitor the patient's level of consciousness. You want to monitor their gag reflex, and that's simply because what some of the anesthesia is a numbing agent for that gag reflex, so they're not choking when they're putting the camera down their throat. You want to watch for aspirations, and that's again because they've gotten medicine to relax everything. If the patient has any chest pain, any difficulty breathing, a cough that just won't go away, if they're swallowing more than normal, those are all things that you need to monitor for. You want to have them cough and deep breathe. If those things don't resolve the situation, that's when you notify the physician. Or even if you're the LPN and you have an RN you're working with, you can notify your RN. You can always troubleshoot with another nurse, but it's always good to know what your emergency plan is. Most places have a code team or they have a team that you can call prior to feeling like someone might start crashing, which means they might start going, thank you, rapid response. So you could call them, and it's not considered an emergency, but they'll come in there and give you a second set of eyes, and they'll assess, and they'll say, yes, we need to do this, or no, we should do this. They have a little more leeway with what they're allowed to do than you do as the floor nurse. And that's not just you because you're an LPN, but it's also the RN. They have more training, so they have more leeway in what they're allowed to do without asking for permission from the provider. Okay. So the next one, that's just an image. Again, that's just being performed at bedside. And then we have a thoracentesis, which is where you are basically removing fluids or air from a person's pleural space. Okay, what happens is there's a large needle. It gets inserted into the chest wall, and they'll either have a filter on it where they just let the air escape if it's a pneumothorax, or if it's fluid. You can see in here they're collecting that fluid. It's that brownish colored fluid in there. And that can be anything from just having too much fluid in the body due to heart failure or ascites, or it can be because there's an infection. It could be because there's blood because of surgery in the lungs. So there's a lot of things that can cause that. Beforehand, this is nothing you would order, but you would definitely want to look into. There needs to have been an x-ray done. You want to make sure the patient is sitting upright with both arms and shoulders on a pillow or over a bedside table. So that tripod position almost. During the procedure, you want to remind them to be very still. You want to make sure they're not coughing or talking. So really keeping them as calm as possible. And sometimes when you have this buildup in your lungs, you're coughing. So doing what you can to prevent that. You as the nurse are going to get the specimen. You're going to send it to the lab. You want to monitor vital signs and breathing. So making sure you know what's normal for that patient is very important, because you're going to communicate that with the doctor or the mid-level that's doing the procedure. And very important here, you want to make sure you remove no more than 1 liter at a time, because if you do, that can cause spasms, it can cause complications, it can cause difficulty in breathing, and it could just set you back that way. After the procedure, you want to apply a dressing over the site where they put the needle in. You have to monitor vital signs every 15 minutes for an hour. We need to have another x-ray done just to make sure the doctor or the mid-level removed what needed to be removed and the lung is moving back where it needs to go. Okay. You also want to watch for bleeding, infection, your signs of infection, you know them: redness, warmth, swelling, odor, drainage, and a pneumothorax. So the pneumothorax can reoccur after that because of the invasion of the needle. Okay. So moving on to chest tubes. I apologize. Here we go. Okay. So chest tubes are very simple. It's basically, it is like a thoracentesis, but it's going to keep the tube in the chest. So it drains blood, fluid, or air from around the lungs, around the heart, or around the esophagus. And you'll see that chest tube it could be in a number of different places in the chest area. You want to keep the keys for the nurse to know. You want to keep the drainage system below chest level. The patient needs to be in a semi-high Fowler's position. You want to check the fluid levels, and you want to make sure all your tubes are clean. Also add that the loop of the chest tube needs to be on the bed, not the floor. Okay, yeah. So again, drainage system needs to be below you, high Fowler's. You want to check fluid levels and connections. You never clamp the tube. If there's a continuous bubbling, that indicates there's an air leak. As Ms. Conley said, the chest tube, this tube, I'm going to highlight it for you guys. This tube is actually in the patient's body, okay? So I'm not sure what's going on this side of the picture, but we don't ever want this to touch anything but the bed, a clean surface. So it needs to be, you can kind of tape it to the patient, you keep it off of the floor, because you're going to introduce organisms in here that literally just crawl up here and can get into the patient's lungs or wherever that chest tube is in, and it can cause issues. Okay, and so this right here, you can see this is what's been drained out of the patient's body so far. Okay, once this is filled up, there's no emptying it. You just get a new one. And each of these systems, there's several different types of chest tubes. You'll just have to familiarize yourself with whichever one is being used where you're working at. And most of the time, you can get another nurse to show you. You can get the respiratory therapist to work with you on it. You can even get the educator at the hospital to go over it with you. So don't ever feel like you're walking into a situation blind. All you have to do is ask for help, and I promise there's going to be help with there, okay? So one thing that you want to keep at bedside is you want to have a clamp, and you want to have sterile petroleum gauze, okay? And most of the time, what I've done in the past is you just tape it to the wall above the bed. And what happens is, if for some reason any part of this tube gets cut, or even if it gets cut somewhere, you can put the clamp on it. I know it says never clamp the tube here, okay? If this tubing is working and functioning properly, you don't want to clamp it. But if for some reason the tubing gets separated, broken, torn, ripped, whatever, then you want to clamp the end of the tube that's hanging out of the patient's body. Okay. And then if for some reason the tube gets pulled out of the patient's body, that's when you're going to take the petroleum gauze and you're going to place it over the hole that's where the tube was in the body. Okay. So now we're getting into respiratory. We have.
You had a question?
Yes, I did. How often should a chest tube be monitored?
You're checking that several times a shift. So anytime you go in the patient's room, you want to check it. And typically you're doing rounding on a patient every hour to every 2 hours. So about that much, about that often. And then, you know, if the patient's showing any signs of distress, then you'll monitor it them as well.
Yeah, because they'll be calling you for pain medicine like every hour. It's not very pleasant, and it's very uncomfortable, and they complain of pain a lot.
And one other thing I didn't mention is when you come on shift, what you want to do is you want to get a Sharpie and you want to just draw a line where the fluid is when you start your shift. You can even just write it down if you want. But that way, during your shift, you can do a better indication of how much drainage has occurred. So let's say you marked it at 900 during your shift, at the start of your shift, and then we're up over here to 1500. You know that from 900 to 1500 is the amount that patient put out during your shift. And that goes into recording ins and outs. That's something that, you know, we'll go over more in the clinical setting, but understanding how much the patient has taken in and how much the patient has put out in any form is helpful, because that helps us understand how much fluid is still in there, so on and so forth. Okay, so back to acute respiratory disorders. So acute is anything that's less than 6 months, but it also just means like simple things that are easily or more easily treated. Okay, so rhinitis is inflammation of the nasal mucous membranes. It can be acute, chronic, or a result of allergies. Common colds are some results of rhinitis, or some causes of rhinitis are the common cold, allergies, and like being allergic to something, having an allergic reaction, and then seasonal allergies. Okay. Most of the time you'll have a low-grade fever, and you'll have stuffy nose, runny nose, which can lead to postnasal drip and stuff like that. And so for this situation, you're going to treat the symptoms, and you're going to usually do things like antipyretics. So you want to keep the fever down, decongestants. You want to make sure that they're getting, if there's anything building up in the nasal cavities, we want to break it down so it doesn't go into the lungs. So you're going to have your decongestants, your antitussives. You can do saline gargles. You can do saline sprays in the nose, and antihistamines to help reduce the inflammation. And again, it's minimizing complications that arise from these conditions. The other condition is sinusitis, which is inflammation of the sinuses or the maxillary sinuses. Results from infection, and I'm sure you've all felt this. It's fever or pressure around the eyes. It's really intense pressure behind your eyes or around your eyes from sinuses. You're going to do saline irrigations. You're going to do antibiotics if it's something that lasts for more than 5 to 7 days. Usually, you can do vasoconstrictors, nasal corticosteroids. Sometimes you might have to have surgery, a Caldwell-Luke procedure, or an external sphenoidectomy. A lot of times what you do is you'll use mouthwash, you'll get humidification, you want to increase your fluid, take your nasal decongestants and your antihistamines. Especially in this area, because of the amount of pollen we have, you will see a lot of these. In this video right here, the link goes to a really good website that Ms. Conley put on here for you guys, that allows you to break down in more detail each of those conditions. Okay. The next condition we'll talk about is pharyngitis, which is simply a sore throat. The pathophys. Thank you. So as Ms. Conley was saying, the Caldwell is a drilled hole in the gum, and it helps drain the sinuses. It's not the most pleasant of procedures, but if it's to that extent, that's necessary. Let's see. Okay, so pharyngitis, you have inflammation of the throat, rhinitis, and other upper respiratory infections. These are typically caused by your group A streptococcus, which are strep throat. So a strep throat is definitely something you want to always monitor for. You will always want to make sure this is treated properly, simply because of the complications that can come of it. Endocarditis, which is the inflammation or the irritation of the endocardium. And your endocardium it's the inner lining of your heart chambers and the heart valves, and this can lead to heart damage. You will see many patients who have heart failure, valve issues, and such because of viral infections. My mom, for example, she was diagnosed in her 30s with a viral infection that went to her heart, and she is now on an LVAD. She's pending heart transplant, and we can talk about LVADs later on if you guys want, but that's the external mechanical device that they basically connect to your heart to allow your heart to pump properly and to allow your heart time to rest. So any of these infections, rheumatic fever, your strep fever, your scarlet fever, stuff like that, any of those things you want to make sure you keep an eye out for. There's testing, it's throat swabs, and then they send them out. Sometimes you can get a rapid result and then treatment. It is highly contagious, and it's via inhalation or direct contamination with droplets. And again, with these conditions, it's symptom management, and then once you know what bacteria is growing, treatment of that bacteria. Okay. To continue on, pharyngitis, you have your findings, which you're going to see are your sore throat, your difficulty swallowing, and just a side note, dysphagia, D-Y-S-P-H-A-G-I-A, is gastric. Think about that G as anything that deals with the gastric, so the mouth, stuff like that, okay? Dysphagia with an S, D-Y-S-P-H-A-S-I-A, is where there are speech issues. That's just a little side note on trying to remember the difference between those two words because they sound exactly the same. So you'll get a fever, you'll have headaches, you'll have white or exudate patch over the tonsil area, which is what we see right here, and swollen glands. Okay. Medical management, again, you're going to do throat cultures and you're going to do antibiotic therapy, which is usually your erythromycin. Okay. Moving on to treatments, you have a tonsillectomy. Let's see. Nursing management includes pre-care, post-care. Nurses be aware of your labs. You need to know your proper ranges for hematocrits, your platelets, your clotting times, aspirin and NSAID use. And then you want to do discharge teaching, which we'll get into. Why do we want to know a patient's clotting time, whether they're using aspirins or whether they're using NSAIDs after someone has had a tonsillectomy? Do you guys know why?
Risk for bleeding.
Correct. After tonsillectomy, you can have hemorrhaging, which is considered a medical emergency, and that bleeding occurs from the mouth or the nose. And what usually happens, you might not necessarily see the patient spitting out blood or having blood, coming out of their nose. You might notice things like they're just swallowing often. There's a lot more swallowing or trying to clear their throat. So if that's happening, they can have just regular bleeding after surgery for up to 2 weeks after the procedure. Sometimes after they get home, the scabs that have formed over the tonsil or where the tonsils were can come off and there'll be a little bleeding. The hemorrhage is completely different and they're going to notice it. Yes, and the way to do that is, as Ms. Conley said, is you want to prevent your nausea and vomiting because you want to decrease the pressure in that area. And if you think about throwing up and all the pressure that comes along with that, that can dislodge, that can damage the tonsils that have just had surgery, okay? So discharge teaching includes you want to talk to them about pain management. You want to talk to them about oral intake and fluids. You want to find out what they're allowed to eat or drink. There you go, cold things only. And sometimes there's an ice collar that they can be provided, even just putting ice on the neck to help with that. And then humidified air is also easier. So if the humidifier available, or even, standing in the bathroom with the shower running, that helps, okay? So going to the next one, a question for you guys, okay? The nurse is providing post-operative care for a client who has undergone a tonsillectomy. In which position will the nurse place the head of the bed when the client is fully awake? You can go ahead and type out some answers. Just do A, B, C, D. Throw some out there for me. Okay. And anybody else have anything? Everyone agree with D?
Yes, D.
Okay. So you're on the right path, but you want to do a 45-degree angle, okay? So 45 is like this. If they're not awake, you're going to do slightly raised. On the side. Oh, yes, I'm sorry. You're correct. On the side, so if you have anything coming up, it'll come out. Yes. Okay. So again, so 90 degree is straight up and down like this. And all you have to do is just think about comfort. Are you going to be comfortable sitting like that? Probably not. So doing the 45-degree angle is a little better. Okay. But you're semi-filers. But again, Raven, you're on the right track. You sitting up is the key, and sitting up for comfort, really. Okay. So good job on that. Thank you for answering. Another question. After a client undergoes surgery to the upper respiratory tract, the nurse should monitor the client for which of the following? Throw out some answers for me, guys. Think about what you've just had done. Correct. Yes. Good job, Raven. It's just me and Raven today. So patent airway, that's the biggest thing. Good job. Thank you, Jacqueline. And anytime you go under any surgery for the respiratory tract, inflammation is an issue, or it can be an issue. So monitoring that airway is really the most important out of all of these. All of these are important things to monitor for, but when you start taking your NCLEX, it's going to be the most important thing to do, which is making sure your airway is patent. ABCs, you want to make sure they're breathing, okay? So moving on to the next one, we have laryngitis, which is inflammation and swelling of the mucous membranes. It's usually caused by upper respiratory infection, excessive use of the voice, allergies, or smoking. I know you hear singers have laryngitis and they have to cancel the concerts and da-da-da-da. That's what it is. Oh, sorry, what's happening? Okay. They're basically overusing their larynx, okay? What you as the nurse will notice is they cannot speak above a whisper. There'll be aphonia, which is basically they're not able to speak at all. There's throat irritation when you do your exam. It'll be red. They'll have a dry, non-productive cough. If you have hoarseness that lasts longer than 2 weeks, they have to have a laryngoscopy done. That's where the doctor goes in there and looks at the larynx. And if they have persistent hoarseness, that could be a sign of laryngeal cancer. But again, if someone who isn't able to speak is doing what they're supposed to do by going to the doctor, it really shouldn't get to this level. But I will tell you, working as a nurse for 10 years now, it's not surprising to get to this level. People will lose their voice and live life with no voice and not think that they should go to the doctor, and then they have laryngeal cancer that has metastasized to other areas of the body. Happens all the time. Does someone want to say something? Yeah, all the time. All the time. So tobacco dip is a big one. They think they're not smoking cigarettes and they'll be okay, but you still get it. So anyway, medical management is going to be voice rest, treatment or removal of the cause if it's, a cancer, antibiotic therapy if it's bacterial, and of course you want to avoid smoking. Any irritant, and that includes anything. So smoking cessation is the big one, but it could be something as simple as stuff that's sprayed in the house to make it smell better. That can irritate that. So looking into what are the triggers for you or what are the triggers for that patient is the best thing, okay? So epistaxis, which is what is that, you guys? What's that medical word?
Nosebleed.
Thank you. So the nurse is teaching first aid class for parents. The topic is treatment for a nosebleed. One of the parents indicates a need for further teaching with the following statement. So they don't understand what you have taught them when they say which of the following. Pinch the soft part of the nose firmly, flush the nose with warm water, we want to apply the ice pack to the back of the neck or the nose, or consult a physician if needed.
B.
Correct. We don't want to add warm water to the mix. Thank you, everybody. Because what does warm water do? It gets things flowing. Ice is going to slow it down. Correct. You don't want to blow your nose, and you don't want to lean forward. Lean backward. Back in the day, everyone was told to lean your head back and pinch your nose, and all you end up doing is swallowing all that blood, and then you have to deal with nausea and vomiting. So let's avoid that. Have them lean forward, pinch the soft part of their nose, use ice, and if it doesn't stop or if you have chronic issues, you want to see your doctor. See. Okay? So endotracheal intubation and mechanical ventilation. Respiratory you'll use these devices in situations where there's respiratory difficulties, if the patient is comatose, and under general anesthesia when you're having a procedure. Okay. Mechanical ventilation, it's negative pressure and positive pressure. It can be anything from BiPAPs and CPAPs. How do you know a patient needs to be suctioned? Anybody? What are some things that you might look for if you're having a patient? Thank you. Good. O2 sats are low. So that's really important if you have a patient who's not verbal and they're intubated. You need to watch those vital signs very closely. I had a nurse friend who was working in the ICU, and the patient was really, it wasn't necessary for them to be at end of life. They were just, intubated for whatever reason. And she kept monitoring the O2 levels, and, they weren't right. And she kept communicating these things to her immediate supervisor and, trying to below 80. I mean, it's different at each facility. It's below 90, sorry. But below 90 is usually the indicator. But when you're working with a specific doctor, they might give you a range. They might say, I don't want this patient below 92, or they might say it's okay to get them down to 88. So it just depends, but a standard number would be 90. So anyway, she monitored the O2. People weren't paying attention to it. It turned out he was having a blood clot, and anyway, long story short, she got respiratory therapy in there. They were able to manage it, but he did end up dying. So it's very important to monitor your levels to understand your ranges, and again, communicate with your providers because each doctor is different. Some doctors want you to have a low blood pressure that might scare you as a nurse to monitor, but there's a reason for it. Sometimes they want the heart to rest. Sometimes that oxygen level, because of decompensation in the lungs, you need it to be low. You don't want to over oxygenate a patient. So communicating with your provider or finding out what their parameters are is very important to understand. To make sure you are in the aware, because we want to depend on each other. We want to work with each other, but just to know, you are the one who's going to be held responsible for anything going on with that patient that you do. So you want to make sure you know what you're allowed to do and what you're not allowed to do, and understanding your scope of practice, as well as understanding the orders that are written. It's very important, okay? Moving on. So we've got influenza, we've got the flu. So we're coming out of flu season. And as you all know, it's highly contagious. Infections, you are infectious from 24 hours before you show symptoms up to 5 days after showing symptoms. Your signs and symptoms include a severe headache, muscle aches, chills, fatigue, fever, nausea, vomiting. Sometimes you can have severe diarrhea and coughing and hypoxia. For example, with the avian flu, which is H5N1. You will put a patient under droplet precautions. They will do saline gargles. You want to make sure you're hydrating this patient, whether it's with PO or IV, and you want to monitor their respiratory status. So again, listening to lungs and understanding lung sounds. Lung sounds can change from the start of a shift to the end of a shift. It can change from day 1 to day 2, and you are going to be the advocate for that patient. So knowing your lung sounds and letting the doctor or the mid-level or whoever know that there's been a change in this person's lung sounds is very important. Its change in vital signs are very important. Oh, okay. I was going to say, I thought I said, did I say droplet? Okay. So,
So like on the, they just did a COVID-19 case study, and
yes.
and that one is considered droplet, airborne, and contact. So I don't want them
Okay.
to get confused. So this one is just droplet. It's not airborne like tuberculosis is airborne.
Okay. Okay. I understand now. Sorry. So the flu is a virus. So we don't treat the flu with antibiotics because it won't work. So there are some antivirals that are available. The key is to get them started within 36 to 48 hours. And it doesn't necessarily make the flu go away. It just decreases the strength of it. So that's why we have the vaccine. Anybody 6 months and older is allowed to get vaccinated. You want to make sure you check for an egg allergy. You want to make sure the patients are not immunocompromised. High risk populations, anybody with diabetes, anybody with cardiac issues, respiratory issues, those are people you want to make sure are getting vaccinated. When you're working at the hospital, when you're working at the skilled nursing facility, any of these places, every year come flu season, everyone is going to be told they have to get the flu vaccine. It is, of course, the patient's choice, but you want to make sure you educate them on the importance of it. What happens every year is the CDC goes out and they determine which strain of the flu virus is what they project to be the most problematic for the year, and they create their vaccine based off of that. And that's why we can get the flu vaccine, but we can still get the flu. Because there are different strains out there. And the flu vaccine you're getting is the flu vaccine with the treatment for the ones they think are going to be the most problematic. Okay. Number one complication from the flu is pneumonia. So moving on into pneumonia. There are several causes of pneumonia, and pneumonia is simply inflammation of the lungs by a bacterial or a viral infection. Immobility contributes to development of pneumonia. You'll see patients who are in the ICU. If they're on ventilators, you have ventilator-acquired pneumonia, which is the last one on there. Anytime that you've got someone who's not taking deep breaths, who's not mobile, fluid secretions, they're just hanging out in the body, and that gives it an opportunity for bacteria to grow or to a virus to get in there and do damage. Okay, you have community-acquired pneumonia, which again is usually a complication of the flu, and then you have healthcare-acquired pneumonia, which is usually resistant to antibiotics, and it's you'll usually see it about 48 hours from exposure to the symptoms. Okay. And last, but it's not listed on here, is aspiration pneumonia. You will see this in patients who have had strokes, patients who are older and have difficulty chewing or swallowing, and that's simply where you swallow food you get food in the lungs, that food hangs out in the lungs, bacteria grows, and then they get pneumonia. And a lot of times these patients will be confused as to why they keep getting pneumonia, because they're not, they don't go out and no one's given them a virus or a bacteria, and you explain it to them that it's because they're not swallowing properly. There's usually a whole thing that goes into it with speech therapy, swallowing studies, and so on and so forth. But that's your other type of pneumonia. Okay. Then we get into the signs and symptoms. You have anxiety, you're fatigued, you're weak, you're coughing sometimes so much you have chest pain or chest discomfort, you have hypoxia and confusion, which as it's noted, you'll see more in older adults. You have fever, chills, flushed face, diaphoresis. What is diaphoresis?
Excessive sweat.
sweating.
Good job. Thank you, guys. You have tachypnea. You have pleuritic chest pain. You're going to have yellow tinged sputum. And then again, with your lung sounds, you'll have the crackles and the wheezing. We've already said coughing. Oxygen levels drop below 95 usually. And because you're coughing so much and your throat is irritated, your lungs are irritated, you can have purulent blood tinged sputum. Okay, so how do we diagnose pneumonia? It's usually a sputum culture, blood cultures. You want to do these before giving antibiotics. You'll see elevated, so we know which bacteria to treat. And then you'll see elevated white blood cells. You'll note hypoxemia. And on a chest x-ray, you'll notice consolidation, which is just kind of a graying out of the area that's infected. And you can look up, there are hundreds of x-rays of any one of these diseases, pneumonia included. In reality, though, you'll never really see the actual chest x-ray image. What you'll see is the report from the radiologist, and it's good to understand or be able to understand what these reports mean. And they really do break them down to where, in lay terms, they break it down to where you'll understand. If you don't have a good grasp on medical terminology, they still break it down into something that you're able to understand. Okay. Okay. So how do we treat patients with pneumonia? You want to have them in a high Fowler's position. You want to encourage them to cough and deep breathe, and that's using the incentive spirometer. That's the little tube thing that's connected to the device that has numbers written on it, and there's a ball that goes up and down when you blow in on it or suck in on it. Okay. You want to make sure they're getting hydration. Hydration, fluids loosen secretions, and that helps clear out the lungs. You can do oral fluids. You can do IV fluids, and you want to make sure they're eating a well-balanced diet. If their oxygen levels are staying low, you want to make sure you're providing them with oxygen. You can do that via nasal cannula. One of the biggest things you'll notice is people don't put their nasal cannula on correctly, so you want to make sure that's on properly. And we'll see if we can do that we're going to try to do a clinical video for you guys, and we'll see if we can work on that so you can see how these things are put in properly, understand how to use them, so on and so forth. Okay. Antibiotics, next line of treatment. If it's bacterial pneumonia, it's usually a cephalosporin that you're going to be giving. Any antibiotic can cause you to have diarrhea, so you want to make sure that they're doing their part. And it's sometimes as simple as letting them know to eat yogurt or take a probiotic, because antibiotic kills all bacteria in the body. It's not just hunting out the bad bacteria. And we have a lot of good bacteria in our intestine, so that's why it causes diarrhea. So if you let them know to do something as simple as eating yogurt, if they don't like yogurt, take a probiotic, so on and so forth, that helps with that. Plus, you want to take it with food on the stomach because it can cause nausea. You want to do your bronchodilators, which reduce bronchospasms and irritation. Albuterol, and again, increase your fluid intake. Albuterol can cause low potassium. It can cause insomnia. It can cause headaches, and it can cause nausea. Does anybody know why albuterol can do that? What does albuterol do in the body? It's very simple if you think about how albuterol works. Have you guys really covered medication yet? Anybody feel okay? So albuterol, what it does is it opens everything up, and so if everything's opened up, it's going to make you jittery, and That's why. So just think about it like that. That's why you're going to have the tachycardia, the elevated heart rate. That's why you're going to have the tremors. That's why you're going to be anxious, because that stuff is basically hyping you up, and it's getting those secretions out. It can cause your blood pressure to go up, and it can cause you to have palpitations. So if a patient is ordered albuterol every 4 hours, what's in the grand picture, in the big picture, you're going to give that patient albuterol every 4 hours. What time of day should you maybe limit when you're giving it? Or
In the evening or at night?
good, at bedtime. So good. In the hospital setting, they're getting it scheduled no matter what, because they're in a situation where they obviously need more help. But when you're teaching them about about discharge at home, you can let them know, hey, if you're going to do albuterol, which we recommend, we want you to do it, try to maybe avoid it 2 hours before bedtime. That way you're not going to be up all night because you're jittery from the albuterol. Ipratropium causes a dry mouth. It causes difficulty urinating. You again want to watch your heart rate. It can cause blurry vision, and it can cause palpitations. So for ipratropium, if you have blurry vision and palpitations, it could be that you're toxic. So that's something that we need to communicate to the doctor or the mid-level, okay? Glucocorticosteroids, also known as your prednisones, your solumedrols. These, if you have a diabetic patient, do not be surprised if you have blood sugars in the 600 to 700 range, especially if they're an uncontrolled diabetic, because steroids increase your blood sugar. And on that same level with everything that we're doing to clear out these lungs, it can increase your blood pressure, and it can cause you to hold on to fluids, okay? And it can cause your entire immune system to be suppressed. So you want to avoid, if someone's on long-term glucocorticosteroids because they have issues often, you want to avoid things that will cause them to basically be infected. So there's that. And then the last thing is you have to taper off of a steroid dose. I'm not sure if anybody's ever been on a steroid dose, but it usually starts with, you'll take, just as an example, you'll take 10 the first day, you'll take 9 the second day, you'll take 8 the third day, so on and so forth. It's very rare that you start out that high, but especially for a respiratory issue, but you'll taper off for several days and get it out of your system that way. So when you're teaching, let's say you have a diabetic patient who's being discharged home on a Medrol pack, which is your steroid dose taper pack, and what's something you want to tell them they should do, or what's something you want to teach them to do? You can type it out. You don't have to say it. You could just say it if you want to. You guys have the answers in your head. You're just scared to say it. Thank you. It's that simple. You want to monitor your blood sugars more frequently. If they have insulin, we need to make sure that their doctor has given them permission to, whatever whether they're on a sliding scale, whether they're on just a dose a couple times a day, whatever the case may be, we want to make sure we can control that blood sugar if they're going home on it. So making sure you teach the patient, and sometimes just teaching the patient to get with their primary doctor so they can have coverage, because sometimes in the hospital setting, that hospitalist isn't concerned about sending them home with a new order for insulin. So just making sure they're aware of it, letting them know what proper ranges are. Again, each provider is different, but it's pretty standard that anything over 300 is going to be where we need to communicate with someone about it, okay? Atelectasis. So atelectasis is inflammation or edema causing alveolar collapse. You're going to have shortness of breath or hypoxemia. You're going to have diminished or absent lung sounds, and a chest x-ray is going to show density. So that's what I was talking about earlier. The density is where the lung has basically the lungs in not in that area anymore. And so what do you want to do about that? Anybody?
Can you repeat that?
What do you want to do for a patient who has atelectasis?
Give them oxygen.
Good, you do. Sometimes it's as simple as getting them to cough and do breathing exercises. Oxygen therapy is very important, and listening to the lungs to find out where that area might be, okay? You guys believe in yourself. I promise you, you know these answers. It is very simple because at the end of the day, our goal is homeostasis. We want to make sure that the patient's body is balanced. So if you understand the patho, if you understand the anatomy, and then you see why it's not balanced, well, all we have to do is think about how are we going to get that patient balanced again. It is that simple. Don't make it more difficult than it is, okay? Oftentimes, especially during tests, we overthink things. We're not here to not let anyone pass. At the end of the day, we want everyone to do good because we want good nurses, okay? So let's look at this next question. An elderly client is brought to the emergency department. Vital signs are 102 Fahrenheit, pulse is 88, respirations are 32, blood pressure is 160/86. You do your physical examination and you see that the client is having difficulty breathing. Which of the following would be the most appropriate for the nurse to do next? Let's just think about what's the easiest thing we can do for this patient. Look at these respirations. What's going on with that patient? Are they maybe beginning to hyperventilate? Good. So who said it earlier? The brown bag, right? If you don't have a brown bag, what you're going to do is you're going to tell them that's also, Tara, that's also.
Can I just make a quick comment here?
Yes.
Okay. The correct answer to this question is actually 3, to apply
Okay.
a pulse oximeter. And
Okay.
does anybody know why?
Because we don't have oxygen levels.
Yeah, so we don't have all the assessment data there yet to determine the next step. So we can do all of those things, but we have to have all of our assessment first, just following the nursing process.
Okay, so Tara is correct. But you can also go and instruct the patient to just take deep breaths in and out. It's that pursed lip breathing, and that'll help calm them down, and that'll help with the oxygen. Okay, but as Tara said, as Ms. Conley said, checking that pulse ox, because we do not have all the vital signs up here, is what's going to get us the data we need. Okay. All right. And look at that. I had the right answer selected and I said the wrong one. Okay, so pleurisy and pleuritis. What are these? Pleurisy and pleuritis, or pleuritis, is inflammation of the peritoneal and the visceral pleura. Assessment findings, you'll have shallow respirations, any excruciating pain, you have a dry cough, you have a patient who fatigues easily, you have dyspnea, and you have friction rubs, okay? So why would this be extremely painful? Just thinking about what's going on, why would that be painful? You basically have these two areas rubbing together, and that can cause a lot of pain. You'll treat it with analgesics and antipyretics and NSAIDs, and you can do heat or cold. You want to do emotional support. You want to do pain management and splinting of the chest. Okay, so we'll move on to pleural effusion. Pleural effusion is simply a collection of fluid between visceral and parietal pleura. It can be caused by tuberculosis. It can be caused by lung cancer. It can be caused by cardiac disease such as heart failure. What you will see when you're assessing that patient, you'll have a fever, they'll have pain, you'll have difficulty breathing, and that friction rub. What the tests that need to be performed are chest radiography, a CT, possibly thoracentesis, depending on how big it is and where it's at, medical management, antibiotics, analgesics, cardiotonic drugs, and a chest tube. Okay, and on the nurse side of things, you would either prep the patient for thoracentesis or a chest tube. You want to educate them on how these devices work, and you want to let them know in a not scary way that there might be some pain, so on and so forth. Okay, the overall goal for anybody with a pleural effusion is you want to get rid of what's causing it. You want to relieve the pain and discomfort. And as Ms. Conley notes on here, if it's a cardiac issue, such as heart failure, diuretics are going to be the best thing, but you also may need a chest tube depending on how advanced their edema is, or their pleural effusion is. Okay. Pulmonary tuberculosis. What is that? Pulmonary tuberculosis is a bacterial infection caused by the Mycobacterium tuberculosis. Its onset is insidious, and that simply means it's a long time coming. You can have it for a while before it even presents itself. The patient will be very fatigued. There'll be anorexia or weight loss, persistent non-productive cough for 3 weeks. You'll have night sweats and a low-grade fever. Night sweats is usually the one that you're going to see related to pulmonary tuberculosis as a sign or a symptom. So keep that in mind, night sweats, a low-grade fever, a productive cough. It'll be mucopurulent or blood-streaked sputum. You'll have weakness, wasting, hemoptysis, and dyspnea. Okay, so how do we test someone for tuberculosis? You'll do the Mantoux tuberculin skin test, also known as the TST. Let's see, 2 to 10 weeks after exposure, you can do the test and you'll get a reading. The reading needs to be performed in 48 to 72 hours after it's done. And really the gold standard of testing is the QuantiFERON TB Gold blood test. It can determine active or latent TB. You can get chest imaging done, a sputum culture, and an acid-fast bacilli smear. Okay. Drug therapy is going to be isoniazid, or also known as INH. And then we're moving on to nursing care. So this gets into PPE and proper room placement. You're going to have your N95, and we've heard a lot about N95 masks. N95, they keep 95% of particles out of the mask. There are actually N99s available, but hospitals usually carry the N95s. Okay, negative pressure room. It basically prevents air from coming into the room. The client should wear a mask. You need to make sure that patient is eating properly and getting proper fluids. You want to do tests on secondary exposure, so family members, friends, anybody the patient's been around. Your medications again, the INH. You need to watch for liver and neurotoxicity. You want to give the vitamin B6 medication, pyridoxine, and you want to monitor your liver functions. Medicine should be taken on an empty stomach, and you should not take it with alcohol. So you can treat patients outpatient. Usually it's done through the health department. And LPNs can get jobs at the health department. I worked recently with a guy who's in charge of the TB program in Glenn County, and what he does is he manages patients. He goes through, because this is government mandated, they have to take their medicine. He'll go through and do checkups at their house. He'll make sure they're taking their medicine. TB medication is provided through local and federal government. It's not something the patient has to worry about. Testing, all that stuff is provided through local and federal government because it at one point in time was such a big issue. Okay. Rifampin is an antibiotic. Again, you want to monitor liver function tests. You want to make sure you tell your patients that when they go pee, their urine will be orange, so they do not have a heart attack, and it will be orange. And like with most antibiotics, or really any antibiotic, if they are on birth control, if they are sexually active, you want to make sure that they know to use a second form of contraception, because any antibiotic can affect how well birth control works. Okay. We've got some other medications listed down here: pyrazinamide, ethambutol, which has been reported to change your vision; streptomycin sulfate, which affects the ears, so you want to make sure you're monitoring for ototoxicity. Okay, you want to directly observe swallowing of the medication, and that goes back to what I was telling you about that manages the TB clinic. He goes to their house and he makes sure they swallow the medicine, and they're treated at home for a full 6 to 12 months. Okay. So here's a question. A 17-year-old client's mother has recently been diagnosed with pulmonary tuberculosis. The nurse would expect the physician to order which of the following tests initially? Give me some answers. Okay. Perfect. The Mantoux test may be read in 3 days and will reveal whether the tuberculin bacilli has entered the client's body. So that's correct, ladies. Okay, so let's move on to asthma. Ms. Conley has this website right here. It goes into great detail about asthma. It's a very good thing to review when you guys have time. In the simplest definition, asthma is a reversible airflow obstruction of the bronchioles from inflammation. Okay, and health promotion, it's very simple. We've been talking about, you want to make sure they're getting their vaccinations. You want to encourage them to stop smoking. Anybody who has asthma that's smoking, I don't know what you're thinking, but you want to stop smoking. You want to recognize and avoid your triggers, anything from air pollution to changes in temperature, perfume, seasonal allergies, dander, so that's pet dander. Foods can sometimes cause people to have allergic reactions, respiratory allergic reactions. Oftentimes, emotions can cause asthma. Medications, chemicals, and just infections in general can cause someone's asthma to act up. Okay, so we'll try to go over use of a metered dose inhaler. If I can get a hold of one, I'll show you guys how to use it. But you want to make sure they're giving themselves medicine correctly, the correct medicine at the correct time. You want to utilize the peak flow meter, and regular exercise helps by promoting ventilation and perfusion, cardiac health, and muscle strength. And sometimes a patient, if they have exercise-induced asthma, they might need to utilize their inhaler prior to exercising. Okay, and so we'll go to signs and symptoms. So signs and symptoms, you have dyspnea, chest tightness, anxiety or stress because you're having shortness of breath and because your chest is feeling tight. you get that coughing and that wheezing. The mucus production is really thick, and that's part of what's causing the asthma exacerbation. You start using accessory muscles. You're taking longer exhales, and as a result, your oxygen levels are dropping. You're having a barrel chest or increased chest diameter, and your ABGs are showing hypoxemia low, which is, CO2 is less than 35 in the beginning, and it can be higher than 45 as it gets worse. So what time do we take singular?
In the evening.
Good. Usually it's around bedtime. Most pulmonologists tell their patients to take them in the evening at bedtime. Okay, so this is an example of a peak flow meter, and it goes into what you're going to do is you're going to take a deep breath in, inhale all the way, and then you're going to blow that air out as fast as possible through that meter. And then on there, it's very hard to see, but there's a green zone, a yellow zone, and a red zone, and it indicates the level of your lungs at that point. Okay, so working with that helps encourage the patient to do those breathing exercises. Let's move on to a question. The nurse is instructing the client with asthma about the importance of measuring peak flow rates. Which of the following statements about the purpose of measuring peak flow rates is correct? They help wean him off of his bronchodilators. They measure his response to bronchodilator therapy. They eliminate the need for blood test monitoring of the drug level. And they determine when he may return to work. Good. It is B. The rationale is it's serial measurements of peak flow rate. They provide objective data of the therapeutics of the drug response. So basically, you're taking the medicine, and then you're doing the test, and it's letting you know how well that medicine is working for you. Okay. So chronic obstructive pulmonary disease, COPD. One thing, I was working with a doctor once, and he very politely let me know, if you do not know what the initials stand for, do not use the initials. So it's very simple. Just learn what the words are behind the initials and then use the initials, because you're going to have a patient who says, COPD, what's that? And yes, you understand COPD, you know what COPD is, but if you can't tell them that it means chronic obstructive pulmonary disease, they're going to look at you a little funny. Okay, so COPD is a term, and it encompasses emphysema and chronic bronchitis. Okay, chronic bronchitis is the hypersecretion of mucus and recurrent or chronic respiratory tract infections. It's usually caused by bronchial asthma, flu, pneumonia, air pollution, and smoking. Okay, and I know you guys have seen the blue bloater, the pink puffer. Chronic bronchitis, which is known as the blue bloater, it's cyanosis. The patient turns blue and red in color, and they have chronic respiratory infections. They're constantly coughing. It's specifically worse in the morning. You'll hear crackles and wheezing. They have a high hematocrit, which means low O2 levels, and they have a high respiratory rate. They have clubbing of the fingernails, and they have hypoxia, again, low O2 sats. They're using their accessory muscles, and they have bronchospasms. Okay. And then you have nursing care. At the end of the day, you really want these patients to stop smoking, but by the time they get to this level, and this is just me being 100% real with you, by the time they get to this level, they've been smoking for 30 or 40 years, and they will tell you to your face to mind your own business because they're not going to stop smoking. So, and that's the nice way of saying it. So no matter what, you still want to, you're doing your due diligence as the nurse to educate them to stop smoking. There are so many treatment options available. There's gums, there's patches, there's pills. It doesn't hurt to encourage. And what I tell patients is we can't reverse what's been done, but we can stop any more damage. And it really is that simple. Sometimes it gets through to them, sometimes it doesn't. Okay. You want to make sure they're doing their job to prevent infections. So that includes getting their flu vaccine, getting their pneumonia vaccine. You want to make sure they're using a meter dose inhaler with a spacer, and they're going to be using bronchodilators and steroids. So again, you have this patient who's on long-term steroid use. They've never had issues with diabetes, but you might find that they pop up and start having type 2 diabetes, and it's because they've been on these steroids for so long. Okay, you want to work with them, make sure you teach them about their diet, energy conservation, which means you want to rest. A lot of people are better in the morning, so you want to make sure they have activities, whatever the activity may be, whether it's from bathing to doing their laundry, you want to have it planned in the morning time. And you want to encourage them to do exercise to build their endurance so they can tolerate activity. But again, we're doing what we can based on the limits of their lungs at this point in time. Okay, and always increase fluids because fluids help break up secretions. So here's your pink puffer, and you can see specifically the lips. You're going to see that specific type of breathing. They have a barrel chest, meaning their chest is larger. They have finger clubbing. They have dyspnea, shallow and rapid respirations. Their heart rate is going to be elevated. They're going to have tachycardia. They're going to do that pursed lip breathing, and they're not able to fully get out what's in the body, and that's why they have that rounder chest, because they're getting that buildup of that CO2. That CO2 retained in the body causes the skin to have a pink undertone, and that leads to respiratory acidosis. Anybody who has a buildup of CO2 is going to start getting anxious, and you might notice short or jerky sentences, and they're going to be really thin because they're losing weight. And a lot of times what happens is a patient chooses between breathing and eating, and breathing is more important to them than eating. So that's kind of where you get that weight loss from. Okay. Plus the body is just burning all sorts of energy just to make it to where you're able to function properly by breathing normally. Okay. And then we have emphysema, nursing care. You want to make sure you're giving them oxygen. You do not want to go over 2 to 3 liters, okay? Too much can cause respiratory failure. If we go back into what we were talking about earlier, they're holding on to this CO2. So keep pushing O2 in, and they're converting the CO2. It's got nowhere to go. That can push you into respiratory failure, okay? You want to practice abdominal breathing and pursed lip breathing. If you want to see what abdominal breathing is, just watch how a child or a baby breathes. You'll see that stomach going up and down and up and down, and that's abdominal breathing. So you want to get them to practice abdominal breathing, and it's the idea of like blowing out candles. Smelling the roses and blowing out the candles is kind of a way to look at it, okay? You want to give them small, frequent meals. Again, like I said earlier, it's because they're making a choice between breathing and eating. It has become so difficult to breathe that eating is an issue. So small meals that are high in protein and high in calories, and you want to make sure you're giving them their fluids, okay? That's pink puffer, that's that one, okay. And so we're coming up on, okay, the COPD patient care plan. So high Fowlers, semi-Fowlers, the tripod position where they're leaning over the tray table. These are all methods to basically set the body in a position where it's making breathing as easy as possible, okay? You want to encourage deep coughing and breathing, and you do that by incentive spirometer, okay? Just, it says it in the name. It's giving you an incentive to take these breaths, okay? So when they're doing this incentive spirometer, you tell them it is normal to cough. We want you to cough, And that is the reason you're doing it. And coughing helps clear out secretions. So don't be surprised if they're spitting stuff out, okay? You want to give oral care after any breathing treatment, so we don't develop thrush. So just simply rinsing their mouth out with water afterwards, is brushing their teeth if they need to, is helpful, okay? You want to teach diaphragmatic breathing, which is what I was talking about earlier with the stomach, and you want to do the pursed lip breathing. That helps control how you're doing your breathing, okay? Chest physiotherapy. Has anybody seen it? Has anybody done it? Do you know what it is? Okay, so tell me about it. What is it like? You can type it out. You don't have to say it.
It's like beating on the chest to kind of break up the mucus in there.
Correct. And you're gonna cup your hands. Let me turn my camera on so you can see it. Can you guys see me? So you're going to cup your hands like this, okay? And let's say this is the patient's back. You just do like that. You want to hear like that popping sound, and you're going to, depending on where this person is having the buildup of secretions, and sometimes you'll have them sitting up to do it. Sometimes you'll have them laying down to do it. Sometimes you'll have them on their side to do it. But yeah, you'll just go through and you'll do that, and that cupping, that helps break it up, and then encouraging the incentive spirometer, that helps them cough it out, okay? And again, we can't stress it enough. At the end of the day, these people are not eating right because they're making the choice between eating and breathing. It's the same thing, yeah. But you can do it manually with your hand, like I was showing you, or you can do it with the device that vibrates the patient's chest wall. So it's the same thing. There's several videos available on, they have vests that you can put on. People with cystic fibrosis use the vests. They have the handheld device that looks like a back massager. And then, of course, you can do it just with your own hand, okay? So, but at the end of the day, we want to make sure we're making sure they're getting their food in, because they are making the decision, am I eating? Am I breathing? And then meal supplements come in very handy here. Thank you, Ms. Conley. Meal supplements come in handy here. You want to make sure you're giving them proper meal supplements. We have Ensure, we have Boost, and we have Glucerna. If a patient has diabetes, which one of those three, Ensure, Boost, or Glucerna, are you giving that patient? Or are you recommending that that patient use? So you would go, thank you, Maria. You would go with Glucerna because Glucerna is made for diabetics. And again, you got to start thinking about the big picture. This person is probably on steroids. A lot of times you'll see these patients on long-term steroid use, and that long-term steroid use is going to cause that sugar to stay high. So what do we want to do to prevent it from getting higher? You want to give them the proper nutrition, the proper supplement. Okay, so we have complications of COPD. Obviously, you're going to get respiratory infections because your lungs aren't doing what they're supposed to do. So how do we prevent that? You want to avoid crowds, and you want to make sure you're getting your vaccinations. I can't tell you how many people are convinced if they get the flu vaccine, they will get the flu. But as I said earlier, there are many strains of the flu hanging out around there. It's just like COVID-19 right now. COVID-19 is in the coronavirus family, and this is just number 19. I mean, this is just COVID-19. So if we treat COVID-19, that doesn't mean that we're not going to have to still treat the other coronaviruses. It's the same with the flu. There are many different types of flu hanging out, and the CDC just looks for the most common that they think are going to impact us, and that's what we get vaccinated for. It is still possible to get the flu. You are not getting the flu because of the flu vaccine. So whether you agree with vaccinations or not, you have to take that out of the picture. What you have to do is give the patient the education they need and let them make their decision. I have given patients education many a time and they still say no. And that's fine with me at the end of the day because this is their body, but I have given them the knowledge they need to make that decision, okay? So pneumonia vaccine, there are 2 pneumonia vaccines. You usually don't get them until you're above 65 or you're immunocompromised, okay? Complications of COPD include right-sided heart failure. And that's simply because the lungs aren't working right, and that's going to lead to the heart not working right. And it's not surprising to see patients with your trifecta, which is, you will see it all the time. You have COPD, you have heart failure, you have diabetes. And I'm telling you right now, you need to learn what to look out for these conditions. You need to learn nursing management of all of these conditions because you will see these all of the time. It will become second nature for you to treat people, to work with people who have these conditions, okay? So right-sided heart failure due to air trapping and alveoli collapse. This causes increased pulmonary pressure. Blood flow through the lung is difficult. It makes cardiac workload increase, and it leads to an enlargement and thickening of right atrium and ventricle, which leads to right-sided heart failure. Okay. Signs and symptoms that you will see are low oxygen. You'll see cyanotic lips. You'll see an enlarged liver. You have your distended neck veins, your dependent edema, and your weight gain secondary to fluid retention. Okay. So you want to make sure they're taking diuretics. When you're looking at a patient's medication list in whatever environment you're working, if you see they have heart failure and they're not on a diuretic, it is okay to question that. It is okay to say, hey, doctor, hey, nurse practitioner, hey, PA, this patient has heart failure and they have edema. Should we have a diuretic on board? Okay, because you are advocating for your patient. You want to monitor their vital signs. And with any patient with heart failure, when you're monitoring vital signs, you want to include a daily weight. Because in a perfect world, we can go to the buffet and eat everything on that buffet, and we are not going to gain 3 pounds in a day. The reason you gain 3 pounds in a day is because your heart or your lungs are not working properly, and you need to monitor that with weights. And that's something you covered probably in the cardiac side of things, but just know that, okay? And then you're going to top it off with IV fluids, IV meds, okay? Anybody who has heart failure, it's a very fine balancing act on how much fluids you're allowed to give. So that's where your lab work comes in and your monitoring the patient's weight comes in, okay? Moving on. Did I skip one? So now we're coming into pulmonary embolism. Pulmonary embolism is a medical emergency. Your patients usually, a pulmonary embolism is an obstruction in the pulmonary artery or branches due to air, blood clots, lipids, tumor, bone marrow, amniotic fluid, foreign matter, and DVTs are the most common cause, okay? So I'm not sure if anybody's ever heard it, but sometimes after women deliver babies, they throw a clot. That's what we call it, throwing a clot. And that's a pulmonary embolism due to, it could be the amniotic fluid. Correct. And sometimes when you break a bone, you throw a clot, and that's due to bone marrow getting into the bloodstream and then getting lodged in lungs or in the heart somewhere, or even in the brain. Okay? So if you think about a blood clot, it's stopping flow of blood. It's that simple. And it could be any one of these objects that are doing it. It can happen in the brain, it can happen in the lungs, it can happen in the heart, it can happen in the legs, in the arms, anywhere in the body, okay? So how do we prevent this? Obviously, the number one thing is stop smoking. You want to make sure you're a healthy weight. You want to make sure you're exercising. You want to make sure you're wearing compression stockings, and you want to avoid long periods of sitting, and you want to make sure you're hydrated. So we want to make sure we're hydrated because if we're dehydrated, our blood is thicker. Just think about that in the simplest terms. So we have a greater risk of getting a clot. So make sure you're hydrated. You want to make sure you're wearing compression stockings if you are sitting. So if you're driving somewhere for a long distance, or if you're taking a flight somewhere, you're not able to get up and move around, that compression helps the muscles continue to work, okay? Exercising, that gets those muscles contracting, which gets those veins moving, which helps prevent the blood clot, okay? Let's move on to the next one. So signs and symptoms of a pulmonary embolism. Your patient will tell you, or will just out of nowhere have anxiety, and it'll be noticeable anxiety, and they will tell you something is not right, and they will have pressure in their chest. It's oftentimes confused, or you can say a differential diagnosis would be a heart attack, okay? They have difficulty catching their breath. They have hemoptysis, and they have pain. There's wheezing, tachypnea, tachycardia, a drop in blood pressure. They're going to start sweating. You're going to notice dropped O2 levels, and they're going to start turning blue, okay? So as an example, a nurse and I were getting ready to discharge a patient. They had been in the hospital. I worked cardiac floor, so they had been in the hospital for chest pain, cardiac related chest pain. The doctor had literally just walked out of the room and said, it's okay, remove the IV, they get to go home, they've been cleared. The nurse goes in there, removes the IV, and the patient's saying something's just not right. And the nurse initially kind of just wrote it off as, well, you know, sometimes patients don't want to go home immediately because they still don't feel comfortable with their diagnosis. So she asks me to come in there and check the patient out. When your patient is white as a ghost or turning blue, and you see, because we still had the vital sign equipment connected, you see that those vital signs are dropping, something is wrong. So we were able to call a code. At this point in time, the person has become unresponsive, and we've removed our IV. So what happens? Now you have to get an IV on an unresponsive patient, which that's a whole nother thing. And I'm going off on a tangent, but I just want you guys to realize that understanding these signs and symptoms, understanding that this patient was immobile in a hospital bed. This patient was just in the hospital for a cardiac condition. This patient was older. Understanding your possible causes helps you understand that what was happening to this patient is she was throwing a clot. She had a DVT, she had a deep vein thrombosis in her leg, which dislodged, and it went into her lungs. So it's very important to understand and to retain these things. So when you are in a situation, it's literally ingrained in your brain. It's just memory. You don't second guess yourself. This is what it is. You call your code, or you ask for a second opinion, and you never feel bad about it. Even if you call a code or you call for rapid response and they're like, there's nothing wrong with your patient, that's fine, because at the end of the day, you have to listen to your gut. You felt like something wasn't right and you asked for help. They came and did another assessment and said, you know what? Nope, everything's fine. Okay? So pulmonary nursing care, how do we as the nurses manage it? You want to make sure they're getting oxygen immediately via face mask. You want to put them in a high Fowler's position. As I said earlier, we pulled IV access, so we had to get IV access back in that patient. You want to check vital signs. You're going to have a cuff on both arms. You want to try to calm that patient down as much as possible. And sometimes it's as simple as speaking to that patient in a very calm tone and just letting them know what you're doing. Saying, okay, we're going to be putting blood pressure cuffs on both of your arms because we want to monitor your blood pressure and your heart rate. We want to get an IV back in you because we want to do this, and so on and so forth, because you're not always able to give that person medicine. So sometimes it's literally just telling that patient what you're doing. You have to be calm for that patient. You have to have a calm face on, even if on the inside you are running around like a chicken with its head cut off, okay? You need to monitor that patient's level of consciousness. You want to make sure the mental status isn't changing. Give medicine always with orders. Your doctor or your mid-level is going to order a heparin drip. And what do we need to monitor with a heparin drip? You guys talked about it the other week when I was on with you. What's the lab work that you need to monitor?
PTT.
Perfect. So you'll be monitoring that, and then it might be possible that none of these other things work, and you have to get the patient prepped for an embolectomy, which is where they go in and remove the embolism. Okay. And so just to go over some terminology with you real quick, a thrombus is what is developed in the blood vessel. And so that's kind of what you see when you see like fat on, clogging arteries or even a blood clot stuck to them. The embolus is what it's called when it's actually moving throughout the body. So these are the same things. It's just one is attached to the vessel and the other one is that attachment broken off and moving through the body. Okay. So we'll move on to cystic fibrosis. Cystic fibrosis is caused due to faulty transport of sodium and chloride. You will see an abnormally thick, sticky mucus. This is an inherited defective autosomal recessive gene. Okay. What you as the nurse see in the patient, they will have frequent respiratory infections. They will be coughing a lot. What they'll cough up is usually purulent sputum. It's usually very thick. They have finger clubbing due to issues with oxygen transport and inhaling oxygen. They have bloody coughing. They have failure to thrive. They have greasy stools. And not that you're going to go around licking your patients, they have very salty tasting skin. Okay. And when I say greasy stools, you will notice clumps of thick mucus, thick grease coming out of that patient. Okay. So how do we diagnose a cystic fibrosis? Okay. Usually, there are three major reasons to suspect cystic fibrosis in children. They are if a child has a lot of respiratory symptoms, if you notice that that child has failure to thrive. Again, they'll have foul-smelling, bulky, greasy stool. And in newborns, the first clinical sign may be meconium ileus, which is impacted meconium in the intestine. Okay. The standard and most reliable diagnostic test for cystic fibrosis is the pilocarpine iontophoresis sweat test. Apologies, everyone. Okay. And it's really just a sweat test. They do a test to measure the patient's sweat, and they see about chloride and sodium levels like we talked about earlier. Okay. Clients who have cystic fibrosis have an increase in sodium and chloride in both saliva and sweat. So how do we care for a patient who has cystic fibrosis? Okay. You want to make sure they're taking their pancreolipase, which is a medicine that the doctor will prescribe for them. And they take that with all meals and snacks. That particular medicine promotes the digestion of fats, carbohydrates, and proteins. The body's not able to do that, so they have to take a medicine that helps do it for them. Okay. You want to make sure they're doing daily aerobic exercise. This stimulates mucus secretion, and it also enhances self-esteem. Because if you think about what you're not allowed to do because of cystic fibrosis, you're at increased risk for infections. A lot of time these people are homebound. It's harder for them to get jobs, although there are perfectly functioning individuals out there with it. But anything you can do to make yourself feel better. Okay. Going back to the chest percussion that we talked about earlier, if you are a cystic fibrosis patient, Most of the time, you're going to have the osculating vest or the wand that they use. And even in some situations, if you don't have any of that stuff, you can do the manual percussion, okay? The patients usually get bronchodilators and respiratory treatments, and you want to make sure that they're eating a healthy, balanced diet and do everything you can to prevent infections. And that, again, always comes back to, are you doing what you can as far as vaccinating? If you're not able to vaccinate, are the people in your life doing their vaccinating? Are you doing hand hygiene? Are you doing mask, wearing your masks if you're supposed to wear masks, all that stuff, okay? So RSV, which is respiratory syncytial virus, it's also known as croup, and it affects infants through children up to 5 years. It's transmitted when a person who is infected coughs or sneezes into the air. This infection can also result from indirect contact with nasal or oral secretions from infected persons. So think about tissues, stuff like that, okay? You want to initiate droplet contact precautions. Most oftentimes, the patient will have laryngitis, so that raspy voice, difficulty speaking. They'll have stridor, and it's usually worse at bedtime, worse at nighttime, okay? Treatments for this condition are a cool humidifier, steroids, bronchodilators, rest, and fluids. Always fluids with respiratory issues because, again, it breaks down those secretions. Suction for the nose and mouth to free secretions if it's available. Anybody who has chronic cystic fibrosis or sometimes if a patient has been treated at home for RSV, the doctor's able to order suction for the patient to use at home, okay? Most of the time, these are hospital settings, though, okay? So let's move on to pneumothorax and hemothorax. Pneumo meaning air, heme meaning blood. You see your air on this side, you see your blood on this side, okay? It's simply a collapsed lung from air escaping or blood collecting in the pleural space. Chest x-ray confirms it. Your signs and symptoms are going to be anxiety, pain, respiratory distress, tracheal deviation. That's something you'll see on the imaging. Reduced or absent breath sounds. That's what I was talking about earlier, is understanding that you have to listen all the way down to the bases of the lungs on a patient. Even if you don't do all 9, make sure you're covering the lobes and getting down here, because usually in the bottoms or on the sides is where you're not hearing that air. You'll hear decreased airflow, okay? Asymmetrical chest wall movement. It literally, you'll see the right side of the chest go up and down, and if it's on the left side, and vice versa, okay? You'll see that unilateral movement and hypoxemia. So as the nurse, we're going to sit that patient up. We're going to give that patient oxygen. We're going to monitor their chest tube if a chest tube has been placed. You're going to give pain meds as ordered. You're going to encourage deep breathing, and your patient is going to complain about this because it hurts. But you want to make sure you're encouraging that deep breathing, because not only do they have this collapsed lung, they're taking pain medicines, and pain medicines do what? Anybody, you can type it out. Pain medicines relax the body, so it decreases respirations. So not only do you have your pneumothorax or your hemothorax working against you, you have pain medicines working against you as well, even though they are necessary, okay? So encouraging them to do deep breaths using that incentive spirometer, and obviously you want to give them anxiety medicine if it's available, because it is very anxious. It's a very anxious time, not being able to breathe properly, okay? So respiratory failure, patho and etiology is simply acute lung injury. It can be caused by aspiration secondary to near drowning, aspiration due to vomiting, drug ingestion or overdose, hematological disorders, smoke inhalation, lung infection, and trauma. And when we say smoke inhalation, it's usually firefighters or anybody who's around something that's burning. You usually find the patient to have increased respiratory rate. They'll be shallow and labored breaths. You'll notice that they're turning blue. You notice they'll use their accessory muscles, always with the anxiety, and then there'll be some confusion because their brain's not getting that oxygen like it's supposed to. You want to give this patient humidified oxygen. That simply means you're going to add distilled water to the mix. I'm not sure if you guys have been in the hospital room yet or if you've seen concentrators yet, but there's a little cup that gets attached to any one of these concentrators, and you'll hear it bubble. Basically, it humidifies the air so it's not dry air coming in. It's nice and moist, okay? Sometimes it progresses to mechanical ventilation, which is simply a vent. And sometimes an artificial airway needs to be put in place, okay? Nursing management overall is you want to assess and monitor the respiratory status, specifically your oxygen level and your lung sounds. And if you are dealing with the ventilator, understanding the ventilator and working with that ventilator to make sure that no alarms are going off and that you understand the alarms if they are going off, okay? Almost done, ladies. So why are we doing what we do? We're going to obtain appropriate labs, antibiotic troughs. A trough basically lets you know how much of the antibiotic the body has processed and if it's doing it in time, if it's holding on to too much. Specifically for vancomycin, you want to make, because that's hard on the kidneys, you want to make sure the body is ridding itself of these medicines properly and not holding on to them, okay? Sputum cultures, again, that's just going to determine what the growth is, and ABGs, that gives us our acidosis, alkalosis, respiratory versus metabolic, okay? It lets us know the baseline of the patient, and that baseline could be the negative, that could be the bad baseline, not the perfect baseline. And then that's what they come in as, and we work our way up from there, okay? You want to do a full respiratory assessment to detect changes or further decompensation as early as possible and notify the MD. So again, what I was talking about earlier is you want to make sure you're doing a proper assessment and you want to make sure you understand what you're assessing. For example, Ms. Conley has on here, wheezing noted on auscultation would potentially indicate steroids and a breathing treatment are needed, while crackles could require suctioning, repositioning, and potential fluid restrictions, okay? So just understanding this means that, and what I'm saying right there is wheezing means you might need steroids because there's inflammation, and you might need a breathing treatment immediately to open those things up, okay? Promote normothermia, which is basically just your patient's body temperature is proper. And that if your patient's body temperature is proper, that means blood is moving properly. That means oxygen is able to attach to red blood cells properly. And that means that blood, that oxygenated blood is able to move through the body properly and perfuse throughout the body, okay? Cluster care, activity intolerance is common because of decreased gas exchange. Cluster your care to conserve your patient's energy for essential tasks like ambulation, coughing, and deep breathing and eating. We've talked about that already several times, okay? We want to promote airway clearance. We do that by coughing. You do not ever want to really give your patient something that stops them from coughing because the goal is to clear the airway and get that stuff out. You want to make sure you're optimizing fluid balance. You want to make sure, as we said earlier, they're getting enough fluids and their intake is proper, okay? You want to assess and treat pain. If the patients are coughing if they're not coughing because their chest is hurting or their ribs are hurting, it basically keeps the fluid building up. So you want to treat pain properly, okay? And it's not always giving morphine as a result of the pain. Sometimes it's doing a muscle relaxer or something like that. But again, that's all stuff you'll discuss with the doctor. Sometimes you don't even have to discuss it with the doctor. You just say, hey, patient's having a lot of pain, they're not coughing, and the doctor will make their recommendation from there, okay? And again, we go back to encouraging coughing, always improving gas exchange. Nutrition, we can't cover these things enough. It's very, the patient's not breathing, so they're not eating. They're not eating, they're not healing. So you need to find ways to make sure they're getting their nutrition, okay? In the hospital setting, if you have a patient on the vent, you're going to be doing IV nutrition anyway. So that's something you don't really have to worry about because the nutritionist manages that. The nutritionist and the doctor manage that. Oh, goodness. Okay, sorry about that. You want to make sure you're giving them oxygen as needed. You want to make sure they have a patent airway. It comes down to, on the nursing side of things, positioning and making sure if they have an advanced airway, whether it's an endotracheal tube or a nasogastric tube, that or a nasotracheal tube, that everything's working properly. Okay, and really, you want to let them rest. Resting allows the body to heal. Give antibiotics as ordered. Make sure you're drawing your troughs as ordered. You want to prevent further infection. So if you're in the hospital setting, making sure that you as a nurse are washing your hands, making sure that family and friends that are coming, if that patient's supposed to be on isolation, guess what? They don't get to go visit their family member, okay? If they are going in there, making sure they're wearing their masks, making sure that they're in the proper room. You want to educate patients and loved ones on all the stuff that we've talked about. And that basically, that covers you, because what happens is you are the advocate for that patient. If that patient can't talk, you need to tell that patient's family member what's going on. And don't ever feel bad about being the bad guy in that situation, because you'll come into a number of dynamics where you'll have someone come in and think they know better, and that patient won't speak up against them. In a very tactful way, you simply let them know that this is how it needs to be done. If they're not happy with that, they're more than welcome to speak with the doctor or your supervisor or whatever the case may be. Okay? So I put together like a 5-question Kahoot. Are you guys interested in playing it, or are you done for the day? Is anybody still there? Okay, we'll play it. Okay, so I'm just going to post the link. Do you guys want to do teams, or do you want to do, it's only 5 questions. Do you want to do teams or one-on-one? We'll just do one-on-one because there's only 9 of you guys in the class still. That'll make it easier, okay? So go to that site and that's the code. So just let me know when you guys are signed in. Who's that scared face? I gave you guys a couple more. Got 9 people on here. Could they be on here and not sitting by the computer, I'm assuming? Should we just go ahead and play with who we have now? Six. All right, we'll just go with you guys. That's perfectly fine with me. So we'll just hit start. And are you guys ready? So just, oh goodness. That music is loud. Did you guys get that one right? Okay, Maria, what did you select? Oh, sorry guys. Okay. It said which one of the okay. So it said which one of the following lab ranges is correct. And we were checking to see what the correct pH range is, okay? So pH is 7.35 to 7.45, okay? And that's one of the ones we talked about in the beginning. I'll read out the question to you, okay? Well, when we go to the next one, I'll read out the question. Can you see the answers? You can't see any of it. Well, what in the hell? All right. Okay, so let me just go to the next one and I'll just read the question out loud. Can you see this now? Which of the following describes wheezing? The first is the sound made when rubbing hair strands together, the sound you make when you laugh too hard, crackling and grating, or sibilant, hissing, or wheezing, sonorous, full, and deep. Good, you guys are answering okay. How do I do that? How do I do that? Let me see if I can share it. So you guys are able to see that. Okay, that's okay. So these are the questions. This is not helping at all, is it? Let's see if that one. Okay, so you guys see that? Okay, so I guess we won't play it as fast as it's going then, okay? But it says which of the following describes wheezing? And the answer is sibilant, hissing or whistling, or sonorous, which is full and deep, okay? So the rubbing of the strands, let me go back to the, I'll tell you what slide it's on. That sounds. Okay, so to go back to slide 13 on that PowerPoint, this is, you could just make a note, that's where you need to look. Crackles resemble static or the sound made by rubbing hair strands together, okay? Wheezing is the sibilant hissing or whistling or sonorous, full and deep, heard during inspiration and expiration, okay? Just think of, when you think about wheezing, think about asthma. If you've ever heard anyone have asthma, it's kind of that, I know that sounds crazy, but it sounds like that. So hissing or whistling is the sound you're looking for, okay? Crackling and grating was just something I added on there. And the sound you make when you laugh too hard was supposed to be the funny question, the funny answer, okay? Are you guys cool with that? Jacqueline, what do you mean by 12? Oh, you were telling me the page it was on? Thank you. Okay, so the next question, I'm going to share it with you guys. Let it run through. Oh, you guys can see it. Okay. So you guys want to give me your answers? Can you see what it says? It says when discharging a client home, does everyone agree with Allie and Maria? This one's taking forever, isn't it? Well, I'll let you know that is the correct answer. This is taking longer than I anticipated. So we'll skip that one. Smoking cessation. Okay. Can you guys see that? Because I'm on the other screen. Perfect. Okay. So don't worry about it, ladies. You guys are doing good. So this is another one of those best answers. What do you think it would be? All right, ladies, you guys did good. It is 3. It's eliminating irritants. And I said it during the lecture, and I can't say it enough. We're going to tell these people to stop smoking every single day that we see them, and they're going to tell us to F off. But it's part of what you're going to just let them know needs to be happening, okay? Just a couple more, I think. Oh, last one, okay? Perfect. That is the answer. Well, this is tough, whoever you are. Good job. Allie, great. Linz, you got it. So you guys, thank you so much for playing this game with me. Honestly, it's my first time putting one together. So you're my guinea pigs, but I appreciate it. Does anybody have any questions over anything that we went over today that I didn't explain well enough, or that you want to go over again, or do you guys feel a little better about it? Did I go in too much detail about things? You're welcome. All right, if you guys feel good about, you're welcome. If you feel good about everything, if you feel like you actually learned something, that's all for today. We can go ahead and exit out. You're welcome. Thank you for participating.